stands for S for single, maintenance, and reliever therapy for asthma. In the past, this is not new. It was started around 2019, and initially the S was for Symbicort, and that's the brand of the inhaler that we use for this type of therapy. Now there's other options, so the S stands for single. And in later guidelines, we're just getting rid of the S, and we're just calling it MART therapy as maintenance and reliever therapy. And the goals of today's talk is to explain why we recommend using the SMART, the rationale and the mechanism of action, to know what dose to use for these inhalers and to use SMART, and to identify some strategies to how to introduce this SMART therapy to your patients. I will say that even though I did fellowship, I finished last year, I started using more MART after listening to Dr. James Creams. He gave a great talk at ATS and then to our fellowship program early this year. And after listening to him, I really started using SMART more, and it really does well. Let's talk first about asthma. So asthma, this is just the WHO definition of asthma. Asthma is a chronic condition. It narrows your airways. You can have inflammation of the airways. Symptoms are wheezing, chest tightness, shortness of breath, coughing. It affects everyone. You have people of all ages having asthma, and most commonly it starts during childhood. And the goal is to keep these symptoms under control and achieve good asthma control following an asthma action plan. Keep in mind that there are different phenotypes of asthma. This is just a graph showing some of the phenotypes. You have the viral recurrent wheezes in early years. You have the atopic asthma, the most common one the allergic asthma. You have also the neutrophilic asthma. You have asthma associated with obesity. So you have different types of asthma and many types of treat asthma. And keep in mind that the younger the patient, the extra responsiveness is the better. What produces asthma? We don't know. So the exact cause of asthma is unknown, and there's a combination of factors beginning from pregnancy, moms exposed to smoke, smoker mothers, the environmental exposures in early years, of course the genes, any kid with a mom or dad with asthma has higher chances of developing asthma. But what we do know is that there are a lot of inflammatory markers involved in asthma. So here on the left, you can see a graph of some of the cytokines and early and late responses of asthma. And if you see the airway epithelium of people with asthma, there's significant changes. So on the right, you see a picture of a person, normal person, and a person with asthma. And you can see the difference just looking at the picture. So a person with asthma have increased airway smooth muscle, has hypertrophy of mucus cells, and you can see that in blue on that picture, has increase of basement membrane. So your airway epithelium doesn't look the same. Just because I'm a visual person, I like this graph from the Allergy and Asthma Networks, and it's asthma in numbers. Asthma is a pretty common disease. About 26 million of America get diagnosed with asthma. 1 in 10 school children will have asthma. And it's a huge cost for the healthcare. It's more than 81 billion. A lot of people is still dying from asthma. It's about more than 4,000 deaths annually because of asthma. And when you see those races, Black Americans are more predisposed to die from asthma compared to Caucasian or Latinos or other races. A lot of people miss school because of asthma, and they miss work also because of asthma. And 3 out of 5 kids will have some degree of physical activity, limiting that because of the asthma. People, to be honest, misuse inhalers frequently. There's 72% of misuse of inhalers. And again, it's a huge cost. A person with asthma spends more than $3,000 per year, managing the asthma. Just looking at numbers, that's the numbers of people in South Dakota. This is adult numbers, but our prevalence is similar to other states, and we have about 55,000 people currently living with asthma, here in South Dakota. When we take a look at the map, compared to other states, we're doing better. The light blue and we're light blue, the prevalence of asthma is less than 8.8%. So of course, compared to other states, we don't have that many asthma, but still, it's a disease that you will see commonly in your practice. Prevalence of asthma is not getting better in the year. So if you compare asthma to other diseases like cancer prevalence is decreasing. The asthma prevalence is not getting any better. And when we see the asthma exacerbations and the visits to ED or admissions, COVID helped asthma because of course people were isolating, they were not exposed to that many viruses. And we saw sort of a decrease with asthma exacerbations, but again, it's not disappearing. People are still going to the ED, getting admitted, getting asthma exacerbations. Mortality of asthma is mostly happening in developing countries. 250 people die from asthma every year. And here in the US, about 11 people die from asthma each day. And what is sad is that if you have the right medications and you have these people like with the right medications and with tools to use at home when they started this asthma exacerbation, nearly all of these deaths, like these 11 deaths per day, could be like preventable for asthma. Inhalers are confusing. So you know this is just a picture of showing like all the treatments and inhalers that we have for asthma. They're expensive and confusing. So just to show how confusing they can be, these are like two different inhalers. One is an inhaler steroid and the other one is a bronchodilator. And if you ask a patient, like, what inhaler are you using when you're like having an exacerbation? What inhaler are you using as your daily med? I think that it's super easy to get confused between these two inhalers and just use the controller as your rescue and the rescue as your controller, or not use one of these inhalers at all. So why use smart therapy? Smart therapy is just to simplify things and make things more easier for your patients and for you guys. So if you have your daily inhaler and you have your rescue inhaler with your MAR or smart therapy, you combine these two and you use one inhaler for everything. So it's the same inhaler that you will use as your rescue inhaler and you will use as your daily medication. And SMART is already recommended for like people 6 and above, and it just simplifies everything for everyone. Why not treat with just albuterol or just with a bronchodilator? So for the last like 50 years, asthma has always been like the first line of treatment, albuterol. And I feel that's what we still do. Like when you see a child in the ED or in primary care with asthma, your first thought is just to send albuterol home and do albuterol as needed if they have like intermittent or mild asthma. In the past, asthma was thought to be a disease of bronchoconstriction, but in the image I showed you, like it's not just the bronchoconstriction of the airway smooth muscle. There are other things going on. There's inflammation. So even though the short-acting like bronchodilator provides some relief of the asthma symptoms, it doesn't do anything about the inflammation of your airway and in the long term. Mild asthma is also like, we're trying like now to stay away from intermittent asthma, mild asthma, because if you tell somebody, oh, this is mild asthma, they are not concerned. And people with mild asthma can still like have serious adverse effects. So in some studies, you see that about 30 to 37% of adults with like acute asthma are classified as mild asthma, not having symptoms the previous 3 months prior getting to the ED or getting admitted. 16% patients of like near fatal asthma, again, don't have any symptoms the 3 months prior. And about 15 to 27% of adults that die from asthma didn't have like any symptoms prior. So mild intermittent asthma is not really like mild. You can still die from asthma. And the triggers for asthma can be very unpredictable. Like, for example, with these smokes coming from Canada, maybe your child was doing great, and then the air quality turned bad, and you went outside, and then it triggered your asthma. Or you could be exposed to any virus or pollens or things in the environment that you cannot control, and then your asthma gets triggered. This is just a graph from one publication showing like a case of a patient. So when you use just short-acting bronchodilators, on the top is a kid, for example, an adult that got exposed to a trigger. And then the blue lines are the reliever. Those are the albuterol. So he got exposed to a trigger. He starts having shortness of breath, chest tightness, has regular asthma symptoms. And then they start using the albuterol, more albuterol, and keep using albuterol until they have to go to the ED, to PCP, to urgent care because their symptoms are not under control. And once the patient is doing like more albuterol, they are like sometimes forgetting to take the maintenance medication, and you're just doing something like opening like the smooth, relax the smooth cell muscles, but you don't do anything about the inflammation. So on the other hand, if you have a patient that has this smart therapy, this ICS and bronchodilator as rescue medication, then same, gets exposed to a trigger, but then you have you start like taking more ICS, LAVA once you start having the symptoms, and you're helping like your short-term symptoms, but you're also like decreasing the inflammation inside the lungs. So in the end, you prevent like a visit to the ED, you prevent a visit to the VCPE, you prevent an admission, and you have like with the airway inflammation. So again, like when you just use albuterol, it's just a beta-2 agonist, so it just relaxes the smooth muscle cells, but it doesn't do anything about the inflammation. There are some studies showing that people using just beta agonists are associated with higher mortality. So here you can see a comparison of how many canisters of albuterol they have used and the mortality. So risk of death of using albuterol increases by 1.9 for every canister per month that you use. So on the top is the people that use albuterol the less, so 0 to 2 canisters, and people here on the bottom are the ones who use more than 11 canisters of albuterol. And the more you use, the more mortality you have. Then albuterol or any like short-acting beta agonist also worsens the delayed inflammatory response. So there are some studies comparing like using like frequent albuterol and using like albuterol versus placebo and other things. And you can see that the recurrent exposure to albuterol like predisposed to a decreased response to SABA later on. So they did some PFTs showing that people that took like albuterol more frequently, then the response to the albuterol is not as good in the PFTs. Then it also like changes the airway eosinophils and then changes the inflammatory markers. When you use inhaled steroids, it helps with the inflammation, and keep in mind that it also increases the beta-2 receptors. And people who use low-dose inhaled steroids prevent death from asthma. Again, this is just another study to show that the more inhaled steroids that you use, then the less likely you are going to die from asthma. And for every ICS canister that you use in the last year, the risk of death decreases by 21% almost. Systemic steroids are great when you need those, but they also have side effects. So why finding new like inhaled steroids? Because the risk of systemic steroids stays forever. So even like 4 to 5 lifetime courses of systemic steroids increase your risk later on of having osteoporosis, diabetes, cataracts, and other things. So even though like systemic steroids are great when you need those, you shouldn't be like prescribing like prednisolone for the kid to take as needed at home. You need to find like a good asthma medication for that. And once you start like doing all these frequent courses of systemic steroids, your risk never like returns to like baseline. So these studies are done like years, like more than 3 years later, or like 10 years later after doing like the courses of systemic steroids, and the risk is still like higher compared to people not getting all those systemic steroids. Now, with the MAR therapy, you're doing both an inhaled corticosteroid and you're doing a long-acting beta agonist. So you're getting all the benefits from having these inhaled steroids and also all the benefits of a short-acting like beta agonist. Why formoterol? So in ICS, LABA, we have ICS with salmeterol and formoterol, but if you want to use this MAR approach, you need to use inhalers that have the formoterol component. And why is that? Because of the onset of action. So if you use salmeterol as a smart therapy, that's not going to work because salmeterol takes longer to start acting. Formoterol acts as fast as the albuterol, so you can do it as needed and have some relief of symptoms. Evidence of why to use this smart therapy. I'm going to show you like some articles that were also like in the GINA PowerPoint's presentation of updates. Basically, when you compare MAR therapy versus step 1 or 2, step 1 is the one you just use albuterol or SABA as needed. Step 2 is the one you use a low-dose ICS plus short-acting beta agonist as needed. And again, when you use the MAR rationale of doing that as needed, the ICS formoterol as needed, you reduce like people from going to the ED, you reduce severe exacerbations, especially compared to just albuterol as needed. And it's almost a 64% reduction. And there's like some studies that show that this like is better with MAR compared to just albuterol or just albuterol and low dose ICS. And again, everything favors this SMART approach. These are just the name of the studies that you will see, like the Sigma, the STAR, and all of them show similar like things, that it prevents severe exacerbation compared to SABA alone or compared to ICS and as needed SABA. Less ED visits, less ED, less admissions to the hospital. And in general, also like patients like this approach more. When you look at the evidence at step 3 and 5 of asthma, and again, as a primary care, I don't know how many of you will become pulmonologists, but if you're working as a PCP or in the primary setting or ED, keep in mind that about 60% of these asthma visits will happen with you. They don't come to the pulmonologist, they go to the ED, to urgent care, or to the PCP to get the asthma under control. And a general pediatrician or somebody like working in ED and urgent care should feel like comfortable managing, I would say, up to a step 3 in asthma. So you should feel comfortable like starting ICS, medium dose, low dose, or ICS LABA, or doing this SMART therapy. And again, when you compare like MART therapy versus keeping just a medium dose ICS or increasing the dose of ICS, MART approach shows less admissions, less visits to the ED, less symptoms, less severe exacerbations. And the population of this study is more than 30,000, so there's plenty of evidence. So that's why GINA is recommended now like a preferred track to use this ICS formoterol medication as needed. And again, this is more simple for your patients, less confusing, just one inhaler for everything. In kids, unfortunately, we don't have that many studies. This is just a couple of studies that we have in the pediatric population. But again, it's showing like less severe like exacerbations and less frequent like ED visits when you use MART compared to ICS or ICS plus SABA as reliever. And what about in exercise-induced asthma? Again, studies have shown that people using the ICS formoterol as needed prior exercise do better compared to using an ICS plus SABA before exercise or just using a SABA before exercise. And this is like showing like improvement like even months later after like doing these medications. So this is like the latest GINA guidelines, the 2024 update. So basically in anybody 5 years and older, up in step 3 and 4, they recommend MART as reliever. In anybody 11 or 12 years and older, MART is a preferred therapy, like in all the steps. If you need to remember something about my talk, is this graph. So what those two of budesonide formoterol to prescribe. Again, here we have budesonide formoterol, Symbicort or Breyna, or the generics budesonide formoterol, and we have mometasone formoterol, that's the Dulera. Keep in mind that most of these studies are done with budesonide formoterol. So if you have to choose, I will say choose budesonide formoterol. But if your insurance is refusing, then you can use mometasone formoterol as a second option to use MART, if you want to use MART. In adults, the dose is a 164.5. In teenagers, it's the same dose, 164.5. And then in kids like less than 11, you use a 84.5 for MART. And the way you do it is based on the symptoms. Again, if you need to remember something, it will be this like graph. If you have daily symptoms, if you have like more than once, like waking up at 9, if you have any reduced like spirometry, then you do for more than 12 years old, 2 puff twice a day, and then as needed. And then if the symptoms are like most of the days, but not every day, then you do once, twice a day, or 2 puff daily. That's what I prefer. It's just easier for the patients, and then as needed. And then if the symptoms are less frequently than 3 to like 5 days, and the normal like spirometry, then you just do the ICS formoterol as needed. And then in kids, you don't do it like in step 1 or 2, but if the kid is having like symptoms more than 2 times a week, but not every day, then you just do 1 puff daily and then as needed. And then if having frequent symptoms almost every day, you do 1 puff 2 times a day and then as needed. So the maximum amount of puff in 24-hour period is 12 for the people 12 and older and 8 for the kids. And the asthma action plan, when you do the MART approach, will look something like this. So then you just choose what dose of budesonide formoterol you are doing, either the 164.5 or the 84.5. And then you tell the patients, if you're starting to have more shortness of breath, cough, any difficulty breathing, just do an extra puff. And interesting is that with the 2 puff, pharmacists will recommend like to brush or rinse the mouth after using that to prevent the oral candidiasis. Studies showing MART using only 1 puff, the risk of having oral candidiasis is the same as the ones using albuterol only, so you don't need to ask the patient to rinse their mouth or like brush their teeth after using the ICS formoterol. Safety is similar, so when we compare safety of this MART approach to just using more albuterol, even like they have like less tachycardia and like better like markers in the blood compared to people using albuterol as needed. So it's a pretty safe approach. And keep in mind that stepping up in asthma is not always the answer. And that's something that we do in clinic a lot. People will lie to you. So there are patients that come to the clinic and they're telling you that they're using their inhaler like every single day. And then you call pharmacy and they haven't done any refill in the last 6 months, or they're really not using the inhaler as they thought. So when you have studies comparing what people self-report and what you can objectively measure, like looking at the doses left in the inhaler or calling pharmacies or that, there's a huge difference, almost 20%. Also, nowadays, when we prescribe asthma medication, we base a lot of our decisions based on insurance, because some insurance like a brand, they don't like the other, and they will cover whatever they want. And of course, we need to adjust that. when you're like comparing the doses of the inhalers for like low, medium, and high, keep in mind that changing to the same like medium dose in different inhalers, it doesn't mean that the potency is going to be the same. So keep taking, I don't know, Asthma next 100 to puff 2 times a day, that you change to fluticasone 110 to puff 2 times a day. Even though it's the same medium dose of ICS, maybe they will respond different to the inhalers. So always like follow up and make sure how they're doing with the inhalers. And when we compare stepping up management, so going from like low dose to medium dose ICS, going from medium to high, or changing to this SMART or MART approach, actually people who change to the MART approach do better and again have less symptoms, less ED visit, less admission. So if you're considering like stepping up in the therapy for asthma, also consider maybe transitioning to this SMART approach and see how your patients do. This is a video. I'm a fan of like these like medical drama shows, and this is one from Dr. House that I wanted to share with you, and I don't think it's working. Let's see. Let me see.
My asthma. They said they'd fix it, but it didn't make any difference at all.
Well, sometimes doctors make mistakes. Anna, you need to try twice as hard to fix them. Are you using your inhaler?
All the time. Go through one a week.
You sure you're using it right?
Do I look like an idiot?
No. Why don't you show me how your inhaler works?
Just to show you that, keep in mind that you can prescribe whatever you want, but if you don't do the teaching, you don't spend sometimes like doing all the training with the patients, teaching them how to use the space of the inhaler, then you won't make any difference. And inhalers again are expensive. So this is just a good research that I did a couple of weeks ago. If a patient doesn't have insurance, how much will you pay out of pocket for this Zulera, Symbicort, generic Symbicort? And it's more than $200, which is like a lot. Keep in mind that a lot of people spend that in groceries in a month. So buying groceries versus buying one inhaler, of course, you're not going to be happy spending that much money or won't be able to spend that much money on inhaler. Lucky for us, starting of June of this year, Symbicort said that he's going to cap the price of these inhalers to $35. So this is something my nurse is doing all the time, like giving coupons to all of our patients. Not that we have anything to do with Symbicort, but for patients that have like big co-payments or don't have insurance, it's better to just pay $35 for the inhaler, and that's something you can do. Then barriers for like doing this SMART or MART approach. It is not approved by the FDA to use as needed. So the US package, sometimes when you go to the pharmacy and pick up the Symbicort or any like the Breyna, you will see that it's not recommended more than 4 puffs in 24-hour period. Some insurance won't cover for more than one inhaler in a month, so they only give patients one and that's it. And some schools want an inhaler to stay at school and then to go home with the patient. So that can be problematic for us. But in general, I think that if you want to try it, it's a good approach. What I try to do is like, I sometimes like put in the instructions to the pharmacy to puff 2 times a day, but then I give the patients a written plan of how to do this SMART approach and how many spacers to do. Most important is like to teach your patients how to manage their asthma. Consider transitioning to this SMART approach of just budesonide for formoterol as monotherapy. It is recommended by like multiple guidelines around the world, including GINA and NAEPP. And again, many studies showing that it's better compared to just SABA or like just albuterol, and it's safe like for everyone. Kids with asthma should be able to do whatever they want. This is just an example that sometimes I show my patients like pictures of like Olympic athletes or like soccer players like with asthma. And in the last Olympic Games, like 60% of Olympic athletes had asthma and they did amazing things. So just keep that in mind and don't limit your kids, don't limit any kid with asthma. They can achieve and do whatever they want. Thank you. If anybody has any questions.
Can you describe a little bit about what like the action plan would be, or what like a rescue would be?
Yeah, so this is just a sample I took from the webpage, but what we do is based on this, you do your asthma action plan. So for example, if you have a kid, 13, 14-year-old teenager that has like daily symptoms, then your green zone will be 2 puffs 2 times a day. And then in the yellow zone, in the asthma action plan, you put add 1 extra puff with spacer as needed every 2 to 4 hours. But what we teach them is that if they're getting closer, like to 12 puff in 24-hour period, they need to either contact their pediatrician to be checked or like let us know to have a sick visit. And then the red zone, instead of albuterol like every 20 minutes, you do 1 puff every 20 minutes on their way to the ED. So you change everything for just budesonide formoterol. Yeah, and this is an example I got from the webpage where they did this like asthma action plan, but again, it's just like clicking whatever they're doing now.
So for an athlete who's in sports who may pre-medicate prior to
Mhm.
an athletic event,
Yeah.
are you letting them do it again if they're partway through the event?
Yeah. So for some of my kids with asthma, I do, depending on how many they're doing per day and how symptomatic they are, I have some kids that I do 1 puff, 15 to 20 minutes prior the race, gym, whatever they do. Some of them I do 2 puff, and then the yellow zone is 1 puff as needed. And again, they can do it as frequently as they want. Yeah, and some kids with only exercise-induced symptoms, I have them like that to use just prior exercise and then as needed. And teenagers, to be honest, love this. Like they feel they have more like control under their asthma. When you tell a kid like do this inhaler like every single day, even though you're feeling great, most likely they won't be compliant with that. With this smart approach, if they feel bad, if they are sick, they can go up on their therapy and they do better. Like we have plenty of teenagers that prefer this approach.
In regards to, you were talking about mild, like the diagnosis of mild asthma and the
Mhm.
association with like hospitalizations and mortality, like, cause I still see it like on charts and stuff like mild intermittent asthma. So what would you suggest like putting as like the diagnostic code and stuff for that?
I just put, to be honest, likely just asthma. I don't like putting, I'm just putting asthma, but for insurance purposes, if I thinking about like biologics or something else, then I do like moderate or severe asthma. But if it's just mild asthma or intermittent asthma, I'm just putting it as asthma. Any other question? Yeah, and keep in mind, like we're just like doing half the work. Like I send these like inhalers, but then I feel like my nurse and Cassie, they're spending like thousands of hours like on the phone with pharmacies and insurance. Good thing is that Medicaid already approved like budesonide formoterol to use, so we're not getting that much pushback from patients with Medicare. But some insurance, like especially the private ones, they want like some documentation. They want to talk with us, and also regarding asthma management, sometimes insurance want you to use some dry powder inhalers or ready inhalers like in a 6-year-old. And patients won't be able like to properly use those inhalers. So just keep that in mind whenever you're prescribing. Of course, you need to follow what insurance are covering, but if they're like the options that are offering are not good for your patient, just try to like do the peer-to-peer, like try to like talk with the pharmacist, find other options.